Good morning. Good morning, everyone. Can you hear me okay? Can you hear me okay? Okay. Okay. Thank you, Dr. Levy. Good morning. Welcome to Geriatrics Grand Rounds. Our #1 Grand Rounds presentation for the year. So big celebration, and thank you to Doctors Gretchen, Orosz and Thomas Johnson for leading the way. The topic today is Let's Take a Step Back, a review of frailty and approach to teaching learners. Just a couple of quick announcements. Our next Grand Rounds will be on the 21st of September with Dr. Christina Vaughn, and the topic will be palliative care in movement disorders. Our next journal club is the 14th of September. That will be via Zoom, and more to come on that. A couple of other announcements. A warm welcome to Drs. Kenny Lum and Kate Runkle for joining the group as faculty. Welcome, everyone. Quick other announcements. Our geriatric division meeting will immediately follow today's presentation of Grand Rounds. You will also receive an email with a link to the recording of today's presentation. So please follow that link and provide some feedback. Also included in the email, so that online evaluation, pardon me. And then please submit questions in the chat or Q&A boxes anytime during the presentation, and then we can check in on those at the end. Our speakers today are, as I mentioned, are Drs. Gretchen Orosz and Thomas Johnson. Dr. Orosz is an associate professor here at the University of Colorado in the Department of Medicine and Division of Geriatrics. She has a long and tenured career here of teaching and working with not just patients, but learners of all varieties. And frailty has been a particular interest of hers, as well as Thomas Johnson, who did his residency and fellowship here at the University of Colorado, and his academic interests include mobility as well as patient safety and frailty. I want to give a warm welcome to them. Thanks so much.
All right, good morning, everybody. Thanks for having us to open up the year. And thanks, Dr. Orosz, for asking me to collaborate with you on this. We were kind of inspired by how our learners oftentimes come into geriatrics with us, and this is the one time we get the opportunity to teach them geriatric topics. And so one of the topics that we think is essential for no matter who the learner is, no matter if they're doing orthopedic surgery, no matter if they're doing pathology, is frailty. And so we wanted to talk about our approach to teaching frailty and also just reviewing some of the basic concepts. We forgot to put a disclosure slide because neither of us have any disclosures. And then our other disclosure, I would say, is that we recognize there's a wealth of knowledge on this topic in this room. So we welcome any feedback and any participation during this time. So our learning objectives. So we're going to define frailty utilizing both phenotypic and stochastic definitions. We're going to identify at least 2 ways to measure frailty in the clinical setting. And then we're going to develop an approach to teaching frailty to learners of all levels. This vignette might seem familiar to those of you that see a lot of patients in this room. So your medical student returns with a pep in their step after seeing your delightful 80-year-old patient. They discuss with you how this patient has had multiple falls, multiple hospitalizations in the past 6 months. They note the patient is complaining of fatigue, muscle weakness. They're now using a wheelchair outside the home. They're losing weight and they're very sedentary. They note the gait speed on the rooming paper, shout out to Gait Speed Initiative, is 0.3 meters per second, very low. So they also note that the patient comes in with 2 major complaints, right knee pain and general health maintenance. They did an excellent job reviewing the chart and saw a previous x-ray of the knee with severe arthritis. They think maybe they'll refer this patient for a knee replacement. They also note, thanks to Epic, that there's a deficiency for screening colonoscopy and mammograms. They have proactively penned these orders for you, but are unsure if we should order them. They know this is not per USPSTF guidelines, but I've seen older patients get these in the clinic that are ordered by other providers. They're kind of confused on that. So at this point, a lot of us would say, okay, let's take a step back and reassess this patient. And so what we're going to do, this will be a little interactive. So we're going to have everybody pair up What we want to do is for people that feel at least remotely comfortable teaching the topic of frailty to have at least 2 people in each group. If you're not comfortable at all even discussing this topic, just join another group of 2. And what we're going to do is each group is going to take, each person in that pair is going to take 2 minutes to discuss the topic of frailty. Then we're going to switch to the other person. And then as a group, we're going to talk about how did that go? Did it feel jumbled? Did you guys have a good approach? Okay. So everybody pair up now and I'll give you timing. Yes. Thank you. Okay, we're actually going to have people come back. We realized we started like 5 minutes late, so so we're just going to have that first presentation, and then we'll do feedback as a group real quick. Oops. Okay, so let's just do thumbs up, thumbs down, thumbs middle. So if you thought you're like, I aced that, like I felt like I had a really good approach to teaching that in 2 minutes, we'll do thumbs up. If you're like, I did pretty well in the middle, if you're like, I was okay, or if I was poor, you can do thumbs down. Can we get that from people? Okay, so like middle, 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 good, 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 good. So we have a variety of confidence in this. So hopefully by the end of this, we'll have a better approach to teaching it very quickly, because oftentimes our learning is only, our time with our learners is very short. And so now I'm going to hand it over to Dr. Orosz to talk about a review of frailty.
Thank you, Dr. Johnson. So most of us, when we saw that case, in our heads were like, yeah, this patient's not going to do well, or, maybe use the word frailty in some way, shape, or form. And we kind of all have this clinical gestalt. You know it when you see it. That's probably not the most helpful approach when we have learners. So I'm going to take a more or less shallow dive into definitions, conceptual framework, and measurements of frailty. So the definition of frailty is evolving. There's disagreement among different camps on exactly what that should include, but sort of our geriatrician's definition, this goes back to Linda Fried's early work, is that it's a biologic syndrome of decreased reserve and resistance to stressors resulting from cumulative declines across multiple physiologic systems and causing vulnerability to adverse outcomes. So that lack of reserve capacity and sort of an inability to achieve homeostasis after an insult to your health. And then going beyond that, all these conceptual frameworks that are evolving, there are three consistent factors that seem to define frailty. And these include, number one, it's that frailty is multidimensional. So it's both physiologic and psychologic factors that are incorporated into that. Number two, it's an extreme consequence of normal aging. So none of us are going to live till we're 200. We'll become frail long before then. And it's dynamic. So individuals can fluctuate in severity of frailty. And I think this is a very important teaching point, which we'll talk about later. Okay, so in those conceptual frameworks, the thought is, does this include multimorbidity? Is it disability, or does it include disability? Is it distinguished from disability? Is there something else? Are there psychosocial factors, or is it a combination of all of these? This is just a little pictorial that can be used to kind of put that conceptual framework into a visual. So if we look at functional abilities, so at the top, those are an independent person. And then as you go further down the scale, that's a more dependent person or more functionally frail. And so on the green graph, that independent person, when they have a minor illness, such as a UTI, they have a small blip in their function down, but a quick recovery, and they get back up to that baseline. In a more dependent person, on the red graph, they have a lower level of function to begin with, and when they have that minor insult, they have a much more deep decline in their functional ability that's hopefully temporary, but as you can see, they have a much slower recovery period, and then they don't quite make it back to that baseline. All right, so now I'm going to move on into measurements of frailty. And the two main camps here are the phenotypic measurement, and then that stochastic or accumulation of deficits, or what we call that frailty index. So phenotypic frailty, the frailty phenotype was developed by Linda Fried and her colleagues using data from the cardiovascular health study. This was a study that went on through the 90s. It included 5,300 adults age 65 and older from two separate cohorts. There was a second cohort added to the original a few years later of about 500 patients that was specifically recruited African Americans into the study. The total cohort received baseline evaluation, and then they were followed annually, depending on which cohort they were in, between 4 and 7 years. So they used surveillance. The surveillance of these subjects included incident disease, falls, disability, hospitalization, and mortality. And then with this data, they proposed to standardize the definition of frailty using this frailty phenotype that could be used for clinical assessment. And it distinguishes, importantly, frailty from disability. So you could be disabled because you lost your arm, but you may not be frail. This is that conceptual framework of that cycle of frailty. So with age, there are declines in, for example, lean muscle mass. So we have sarcopenia on the right-hand side of the slide, and that loss of muscle mass leads to a decreased resting metabolic rate, less energy expenditure, and then anorexia because you have less energy expenditure, which leads to chronic undernutrition, and that cycle just sort of repeats. And this is what they came up with. So this is that operation. All right, we're going to operationalize the phenotype of frailty. Sorry, I needed another half a cup of caffeine. All right, And so the 5 characteristics of frailty are in column A on the left-hand side. So many of you are probably familiar with these. So the first is shrinking, or what we call weight loss or sarcopenia. And from the cardiovascular health in column B, what they used to measure that was a baseline loss of greater than 10 pounds unintentionally in the prior year. The second characteristic is weakness. So this is measured by grip strength in the cardiovascular study, and that was the lowest 20% by gender and body mass index. The third characteristic is poor endurance or exhaustion, and this is self-report. Right now, I think Thomas and I are both a little exhausted, so hopefully we'll recover, though, back to homeostasis. The fourth is slowness, and that was measured by walking time. 15 feet, and that was the slowest 20%. And then low activity, and this is measured in kilocalories per week, and the lowest 20% there. And as you can see, some of these measures are probably not practical in the clinical setting in a quick teaching moment. And then in C at the very bottom right, the presence of frailty is you're positive for the frailty phenotype if you have greater than or equal to 3 of these characteristics. Intermediate or pre-frail is 1 or 2 of these criteria are present. So Thomas and I are probably in that pre-frail right now. And just to reiterate then that frailty does not equal disability. This slide was used with permission. So this gentleman, I can tell by how he is gripping this walker that his grip strength, I don't even need to measure it. He's well above that lower 20%. And you kind of see some white knuckles there on there. So I think his kilocalorie expenditure is probably also above that last quintile. Okay, now we'll move on to the frailty index. So this is the second type of measurement, and the original was published by Rockwood and Mitnitsky back in 2001, the same year the frailty phenotype was published by Dr. Freed. And they took a different approach, and their approach was an accumulation of age-related deficits. So these included symptoms, signs, functional impairments, diseases, which is not on there, and abnormal labs. Their original index included 92 variables, and the index was the number of deficits somebody had out of those 92 over the number of those variables measured. So you came up with a score between 0 and 1. So 0 is a totally intact person, 1 is at the extreme end of frailty. And some of the variables just out of those 92 that they measured included sleep, sleep changes, incontinence, hypertension, a history of stroke, history of malignancy, tremor, impaired abstract thinking, abnormal creatinine, abnormal TSH, and the list goes on and on. As you know, there's 92. I'm going to turn it over to Thomas.
So we're going to talk about some scales and some tools that are a little bit more useful in the clinical setting. So, I mean, we get 40 minutes in geriatrics to see our patients. So we should be able to do a 92 item instrument like on every single patient. I'm not there yet, but I'm sure some of you are. So I like this one. This is the Edmonton Frail Scale. What's really cool about this is that it's been validated against the phenotypic and deficit accumulation definitions of frailty and has really good reliability. But what's most important is that it takes less than 5 minutes for general practitioners to administer in studies. So it's lean, it's mean, and we can actually utilize this. What's interesting though is when we think back to these conceptual frameworks, if we think, okay, are we just relying on the phenotype or do we care about these other factors, cognitive, psychosocial factors? This one gets at a lot of these other factors. I don't know if you can read that. So I'm just going to say some of the domains that this assess. So cognition, talks about how many medications they use, talks about their mood, if they're continent, in their functional performance. So all these domains give you an idea that there's maybe a different approach than the phenotypic definition of frailty here, but it's still a useful tool. Another one, this is called the Frail scale. So this is a dot phrase that I have. So for all of those clinicians in here, you can steal it from my smart phrases. So Frail stands for fatigue, resistance, ambulation, illnesses, and loss of weight. And a lot of these align really nicely with that phenotypic definition of frailty. So if you think about slow gait speed, weakness, exhaustion, not very active, and weight loss, you can see how this lines up pretty nicely with the Frail scale. So some of the questions you would ask for this: have you felt fatigued most or all of the time this past month? Do you have difficulty climbing a flight of stairs? Do you have difficulty walking 1 block? So you can see how this gets at exhaustion, gait speed, weakness. Illnesses, this is where we stray a little bit. And so it's just talking about if you have 5 or more of these major illnesses listed here, and then weight loss 5% in the last year. And you don't even have to remember more than just the phenotypic definition of frailty, because you just need to remember the number 3. So if you have 3 out of 5 of these criteria, the patient is frail. And I've seen this used in the literature in a lot of QI projects presented at AGS as well. So this is something that MAs can also administer.
And so the point of putting this grand rounds together was not for research purposes. Which scale do you use, or how do you measure frailty in your research study? Which one is better? We wanted to stress the importance of teaching frailty and why we do this and how we do this. So why we teach frailty is, number one, to avoid harm. We don't want to do anything to make somebody more frail. It's helpful in clinical decision making. So where somebody lands on that frail scale or whatever measurement we use to determine frailty, will determine, where we are on that spectrum of being aggressive, less aggressive. Are we transitioning into palliative care, et cetera? It also is important, because we talked about before how you can move up and down on that frailty scale on the severity, is that there are interventions that can improve frailty, and there's interventions that can prevent frailty. And then finally, to fight ageism. So it's not a number that we're treating that determines the intervention that we may do. It's how robust a person is, how likely are they to achieve homeostasis depending on the treatment we do. And an example is, like, we've all had 70-year-olds who are frail in their own way and have severe arthritis and want a knee replacement, and you just know they're just not going to do well. As opposed to a patient I had in clinic who was 95, he used to walk his 2 miles a day, and then his hip started bothering him, and physical therapy didn't help, and he had bone on bone arthritis in that hip, and he said, I'm too old to have a hip replacement. And then a couple months later, he got up to go to the bathroom, caught his foot on the bedpost, and went down and broke that hip. And I thought, oh, I'm never going to see this guy again. And 6 weeks later, he was back in my office, and he said, because he broke his femoral neck, so they had to do a bipolar prosthesis. He said, that was the best thing that happened to me. I should have had that surgery months ago.
And so one thing we like to emphasize to our learners is why frailty is important to learn about. And so here's a really cool graph that shows mortality and different causes of mortality. And so what you'll see at the top of each of these graphs, except for cerebrovascular disease, is a small dotted line, and that represents patients who are frail. Then you'll see a longer dotted line below that for patients that are pre-frail according to the phenotypic definition. And then finally, you'll see the solid line. And so those are patients that are robust or not frail. So what you can see in all these different domains is that frailty matters for mortality. And what's interesting, this study went through the work of getting the phenotypic definition of frailty. So doing all those measurements instead of just saying, okay, if they have, according to the frailty index, if they have a high creatinine, if they have incontinence, all these things, we would maybe assume that would be more likely to have a high mortality. But these are according to the phenotypic definition. And so what's interesting, though, is that in dementia, we see that there's actually no statistically significant difference between pre-frail and robust, but there is that signal for, there is this significance for frailty. And then cerebrovascular disease, there's no difference between all of these. This paper goes into more details why they think this happens. What we have seen, though, with the increased mortality is that this is shown across both phenotypic and stochastic definitions. And there are also many studies published during the pandemic that showed that COVID-19 infections also are impacted by frailty. So COVID-19, patients who get COVID-19 or more frail have much higher mortality, as we would expect. This is a really interesting study, and I think it's something that really hits at the heart of geriatricians and palliative care providers, what we see in frailty. And so it's super important to identify frailty because we are more likely to have different conversations with our patients. We're more likely to dive into that M of what matters most if we recognize the patient is frail. So this study, all these patients are the same Edmonton Frail Scale score. So you can see 11.5, 11.5 in these two different groups. So they're just as frail. One group was recognized as frail in the hospital, and the other group was not recognized as frail. And so what they noticed is that the DNR at discharge was much higher for the patients in the group that was recognized as frail compared to the group that was not recognized as frail. And you can look below, and there's actually no difference in mortality at 1 year. And so it's not like this group was dying more frequently because of those that decision making. So many would argue that maybe we're having better conversations with these patients and having more honest, realistic conversations when we recognize they're frail. It's also important because we want to counsel for surgeries like in our clinical vignette, but also therapies, chemotherapy, et cetera. So one trial that really gets at this is the prehab RCT. So this is looking at the concept of prehabilitation. So if we get patients in with PT, OT, nutrition before, in this case, an oncologic surgery, are they going to do better than the patients that are frail that we just have them go into the surgery with normal care? And so the study actually did not see a difference between the groups overall, those randomized to prehabilitation versus those that were randomized to usual care. However, what they noted was that the patients that had 80% adherence, which was their desired adherence rate. So the patients that actually participated, attended those PT, OT, nutrition sessions, those people saw improvements in complication rate, 6-minute walk time, so functional status and disability scores. So it makes a difference in how these patients do when they have these surgeries. And so this is something we can consider for our patients who are frail, sending them to PT, OT, and counseling them on nutrition services before they have these surgeries. It's also important because we need to counsel our patients on what their life may look like. We talked about how this is a dynamic state, and so it's something that's important for us to try to fight against, to treat. And we'll talk about that in a second, but we also need to make sure that if a patient is frail and we're concerned that they're going to stay frail or their frailty is going to progress, we want to counsel them about what life may look like. We have a lot of patients who their goal is to age in place, and so we want to make sure that we can help them reach that goal. This study was really interesting. It's out of Japan, so a different healthcare system, but I thought it was interesting still. So it looked at patients who are identified as frail or pre-frail and looked at their long-term care utilization in the future. And the odds ratios were much higher for those frail and pre-frail patients. So we need to take that step to counsel patients. Hey, I know your goal is to age in place. This is what that may look like. These are the services you may need down the line. So this is something we should explore with our social work. We should explore with your children. Come up with a game plan so we make sure that we have an understanding of where we can go in the future. So some of the treatment modalities for frailty. So one is exercise. A lot of our patients, they identify that, hey, I exercise every single day. I take my little chihuahua out once a day, and I go for a 5-minute walk and come back. I'm like the fittest person in my senior living facility. And so a lot of times that's if you just ask them what they're doing for exercise, they say, I exercise all the time. You don't need to worry about me. But it's just walking, and that actually doesn't meet our CDC recommendations for older adults and their physical activity. And the most important aspect of exercise for these patients is resistance training. So patients who are frail, we have to fight against that sarcopenia that's been developing in them. Occupational therapy, physical therapy also can be very useful to develop treatment plans for these patients. Nutrition, we need to optimize their nutrition. We need to make sure that they're having a high protein diet. Medication review, we're big on the 5 M's, so make sure that we're trying to minimize medications that decrease energy, try to minimize medications that may be decreasing their appetite. Hormonal supplementation, we have an expert in the room listening to this, I'm sure, who is an expert on frailty and hormonal supplementations. That'll be outside the scope of this talk. And then finally, as we discussed before, advanced care planning and counseling is vital for these patients. So getting back to those 5 M's. So now we're going to move on to an approach to teaching frailty. Okay, so 1-minute preceptor. Can you raise your hand if you've ever heard of that term before, 1-minute preceptor? Anyone? Okay, we did have grand rounds last year that talked about 1-minute preceptors. So, okay, so I won't even ask the follow-up questions. So this is good. So time-spaced repetition is an evidence-proven way to increase learning. So we've had 1 year to learn about 1-minute preceptor, and now we're going to revisit that. So maybe next year we can really go through this. So 1-minute preceptor, honestly, I think a lot of you in the room probably do aspects of this, but this is a great way to teach learners. And for all the residents in the room, this is a great way to teach your med students, your interns. And so this is a quick way, supposed to take 1 minute to really dive in and have high quality teaching for your learners. So I'm going to invite up, not yet. I have to talk about the 1-minute preceptor. We're going to show you in a second, though, what 1-minute preceptor looks like. I'm not going to make any of you come up and practice with me. So the first aspect of 1-minute preceptor is to get a commitment. And I feel like this is one of the most important things that oftentimes our learners skip over. So a lot of times, I'll have them present these patients. You notice this in the clinical vignette. They say, I think I might do this. I've seen some people do this before, and I've read this study that would do this third option. So I would do one of those maybe. In making decisions is one of the most essential functions of being a leader. It's one of the most essential functions of being a provider. And so this is a skill that we actually need to practice. So if we don't force our learners to practice that skill in the safe environment, that first year attending is going to be a lot harder. That first night shift in the ICU is going to be a lot harder. So we need to focus on getting that commitment. I had one learner at the VA, and he was in his sub-I, and he really struggled with this. And he taught me something because what he would say every time before he'd present his plan is he'd go, okay, MD stands for makes decisions. MD stands for makes decisions. And he would throw something out there. Honestly, he was a struggling learner. A lot of times it was wrong, but he practiced that skill of making that decision, and he felt more empowered because he was making those decisions and he was at least trying instead of just hedging his bets. We want to create a space where it's okay to be wrong. The next aspect of 1-minute preceptor is to probe for supporting evidence. So we want to know why they made the decision they did. And this is where a lot of times I feel like the R2s, the R3s, so the higher level learners, they may know what the correct decision is, but they don't know why we made that decision. And so you want to ask them, okay, why did you make that decision? A lot of times it's like, I saw the last clinical provider make that decision. They don't know why they're making this decision. And so that's an opportunity for learning we might miss if we just say, you got this right, you got this right. So the next part is just evaluating that encounter. So reinforcing what went well. Even if, they totally got everything wrong in their plan, you can still reinforce. You gathered that information really well. You did a good job there. You offer constructive feedback on errors, and it's important to point out the actual error that they made, not just saying what the right answer is, but actually really diving into this is why this was incorrect. And then finally, you dive into teaching a general principle. And so we're going to practice now. And so we're going to think back to that case. Dr. Orosz will now turn into student Dr. Orosz. And, I feel like she might have
Be in the clinics finally.
finally. And so I think she might have a great career in geriatrics ahead of her. But this case was kind of a rough first start. And so, student Dr. Orosz, I noticed that when you were talking about your plan, you kind of made a couple things that you were thinking about doing. Let's pretend I wasn't here. What decisions would you make if this was your clinic today? Would you send that patient to orthopedics for surgery? Would you get a mammogram? Would you order a colonoscopy?
Well, I think I would send her for a mammogram, and I would definitely want to send her to orthopedics to look about getting that knee fixed.
I'm wondering when you're making these decisions, one, let's just talk about that knee replacement. What helped you make that decision? I want to send this patient to orthopedics.
Well, was her main complaint, and she's really having a hard time getting around. And so I think if we could fix the problem, she would be able to get around a lot better.
And then I heard you want to order that mammogram. Why did you want to do that?
Well, I mean, she's 80, so even though the U.S. Preventive Service Task Force says that she's over that age, I've seen in this clinic some other providers order mammograms on 80-year-olds.
That's great. Well, I think you did a really great job. You knew what USPSTF guidelines were, and a lot of our learners don't know that. I think you did a really great job. I also heard during your presentation, you had a really good sense of how this patient was doing overall. You kind of mentioned these things, multiple hospitalizations, and you painted this really good picture that really told me what this patient was looking like. So I think you did a really great job with that. I'm wondering though, I didn't hear you connect that this patient was not doing well overall, these multiple hospitalizations. I didn't hear you connect that into your reasoning for surgery or mammograms. I'm wondering, has anyone ever taught you about the concept of frailty?
Not really.
Well, let's talk about that. All right, so now we're going to talk about it. Okay, so these were just some examples if you wanted to read along. I don't think we necessarily followed this, which is the point. So a lot of times at this point, if I want to teach this very quickly, I just draw it out. And so I draw, this is, the extent of my artistry would be a stick figure. So I draw out a stick figure, and I find that this is a useful way because you get to hear from them what they've seen before. So I ask them, like, when you walked into that patient room, I want to tell you, I want you to tell me, what did you notice about this patient that maybe set off some alarm bells? When you hear the term frailty, what makes you think that this patient might be frail? And so a lot of times, they might say, oh, I noticed their gait speed was really slow on the rooming paperwork. Most of the time, though, honestly, I hear from them, this patient was cachectic. I noticed that they've been losing weight. And the patient said that they're very tired. They're very tired appearing when they're in clinic today. Could see them, kind of nodding off. They might have some muscle weakness. And so they noticed, like, this patient needed help to get out of the chair. And then they're very sedentary. I heard the caregivers say that all they do all day is watch Fox, or they, watch whatever news station they're watching. That's all they do all day is they sit down and they watch Fox. And so this can get back at that phenotypic definition. And so it's a great opportunity for you to start teaching them if you can hear some of these terms. However, sometimes they also bring up some other things. They might say, this patient's in a wheelchair, and that's a great opportunity to say, hey, just because a patient's in a wheelchair, just because they have disability, does not mean that patient's frail. So there might be a disease process that's going on besides this, and you can go back to, but if they have this muscle weakness, if they have this fatigue, they might need those assistive devices because of those issues, and then they are frail. They also might bring up, I noticed that their cognition is poor, things like that, or they're on a lot of medications, and it's an opportunity for teaching and diving into that idea. And so then, if I have 1 minute, we did that stick figure, and then we talk about, we draw it out. And so this first figure is that one that we talked about earlier. So comparing two patients, one frail, one non-frail. So the patient on the green line is a robust patient. The patient on the red line's frail. So I point out it takes them a lot longer to get better from these insults, and their functional ability does not return back to baseline, even with a minor insult. And so I tend to actually combine these graphs. So you can see the green line kind of matches up with the trajectory on the right. And so on the right, we have a guideline from the British Geriatric Society about end of life and frailty and how to visualize this. And so you can see if you combine these two graphs, you know, a patient who's robust, but then they start developing frailty on the right-hand side. And so we can see that every acute illness, they're not returning back to their baseline. We see that slope, and that'll eventually lead to more functional dependence and then ultimately to the patient's demise. And so I use that to provide a visual analogy. Another visual analogy, if you remember, we had a picture of Golden State Bridge earlier, and so we're going to talk about why we brought that up. This is actually published in literature as a way to think through frailty, and I find that this one is a really good bang for your buck when you have really limited time in explaining frailty. You don't need to go into the phenotypic and stochastic definitions, but it does give a concept. And so basically the idea is thinking about the Golden Gate Bridge. This is a structure we want to last for a long, long time. And that's a very important job. It transports cars, you know, and so we want people to safely be able to cross that bridge, especially when a storm comes. So if a storm's coming, we want to make sure that that structural integrity of that bridge is doing great. And so one can imagine that with over time, if we're not taking good care of this bridge, if we're not regularly engaging in upkeep, when a storm comes, it might not be safe for cars to travel on that bridge. And as that progresses over time, that bridge may fall apart. And so in the literature, they talk about looking at the bridge in terms of the phenotypic definition, the stochastic definition. The stochastic definition is a little bit easier to visualize. So it's a bunch of very small frays and those small wires coming down from the major supports in the bridge. Just some little frays here, little frays there, maybe 92 of them over time. And so that might result in instability of this bridge. The phenotypic definition, these are, you know, pretty obvious signs of damage to this bridge. And so it might alarm people a little bit quicker. So on those major supports, seeing some damage, seeing some cracks, things like that. This can help us identify these patients who are frail. We're not going to talk about resilience today, but that's kind of the opposite of frailty. So recovering from these insults. So sometimes if I have a little bit more time, we will go into a chalk talk. This will be, you know, if I have 5 to 10 minutes instead of that 1 minute, 2 minutes of a 1 minute preceptor. And you can see I always go back to our visual analogies here at the top. So that's supposed to be the Golden Gate Bridge. Like I said, stick figures as good of an artist as I am. And so that's the bridge. And so I talk through that. I might draw some X's. I might erase parts of it to demonstrate the damages over time with frailty. And then there's a graph there that's kind of imitating two different patients. So one that's frail. So with an insult, you can see the slope of the line of their function is worse. And then one is less frail. So even though they're more functionally dependent, this patient, the slope of the line doesn't decrease very much. So that highlights to our learners that disability is not the same thing as frailty. And so then I go through the two definitions. We didn't talk about pathophysiology today, but I talk about that because we're really supposed to with medical students. And then I really try to highlight the why and what do we do about it. And so talking about differential diagnosis, labs we want to order, and then but our treatment. And then I go through those studies that we talked about earlier, just at a very high level, just say there's increased mortality. You're more likely to do advanced care planning. You're more likely to counsel for these patients with surgeries, things like that. And then finally, if it's a very formal setting, I have a lecture for this, and I'll put this in the Seniors Clinic Teams folder for everybody to use. Please don't edit it in the Teams folder. Download it if you want to edit it and edit on your computer. And then anyone who's listening who's not a part of the Seniors Clinic teams, if you want the chalk talk, you can, or the lecture, you can just shoot me an email and I'll send it to you.
All right, so just going back to the clinical vignette, your medical student returns with that pep in their step. And so rather than break up into groups again, we kind of went through a little teaching scenario, Thomas and I, and want to go back to the group here to see if anybody has any additional teaching points that you might give to these learners. So throw out, we just kind of did a brief. Anybody? More coffee in the corner, around the corner? Okay, prognosis would be one.
What do you tell them to expect with improvements or not in walking speed?
What do we tell?
Yeah, so as you're teaching them walking speed so important, if the walking speed's the same the next visit, is that good or is that our intervention?
So if we did know interventions and their walking speed is the same, that's probably good. But I think we can use the point of walking speed being a marker for frailty. And if we can improve that with an intervention and make this patient less frail, then perhaps maybe she would be a candidate for something a little bit more invasive.
I like
Okay.
quick gait speed. So
Yeah.
if we improve it by 0.1 meters per second, even transiently, we can actually see a mortality benefit. And it might be bigger than statins for older adults.
Woohoo! All right. Well, to take people off the hook and in the interest of time, these are, three possible teaching points. How is the patient's physical function? Emphasize the importance of watching that patient walk or tug, etc. And then, is this patient sick or not sick? And this, we would highlight the difference, with frailty versus disability. And then also points about like this sick or not sick on the inpatient side versus when somebody walks into your clinic, what's that, kind of level of sickness? And then, and then disability not equaling frailty. All right. And so then just to sum up, going back to our learning objectives, we hope that we provided a definition for frailty using both those phenotypic and stochastic methods. We identified 2 ways to measure frailty in the clinical setting and hopefully helped you develop this approach to teaching frailty to learners of all different levels. And we will open it up for questions. Enough time? Yes. And are you moderating if anybody's on line asking questions? Okay. I'm told that if you're on the video that you can unmute and ask a question. There's a chat.
I was going to give Dr. Walker a shout out because he actually does measure grip strength and he's probably like one of the few of us that actually does. So yeah, he's pointing that out too. And you can add your name to the whiteboard on how good your grip strength is.
Thank you very much to our speakers. Do we have any questions in the audience here? We'll wait for chat questions online as well.
Sarah.
Yes. Thank you for the question. Just for those online, the question was, what percentage of patients in our geriatrics clinic would be considered frail?
Well, I'll answer from my patient population that it depends on which clinic. So we have our Lone Tree South Seniors Clinic, where my patient population is on average, I think, probably 5 years older than the Anschutz population, but are of a higher socioeconomic status, have more resources, highly educated. And so I would say the frail population there, maybe 20%. And at Anschutz, just sort of by I know it when I see it, not formal measures, I would say, upwards to 40 to 50%. And keep in mind, our age population is 75 and above, unlike internal medicine or sort of the definition of geriatrics is Medicare 65 and older. So we do have an older population. I don't know, Thomas, do you have any?
Yeah, and we know like 29% of those gait speed measurements, if we use that as a hallmark, are in the frail zone.
Dr. Lum.
So as we teach, we hope that people will use it. So how could a health system have integrated ways to measure frailty? Do you think that that should be done routinely? Who should it be done among?
So the question for our online folks was, when we think about our health system, how do we measure frailty, and then how do we incorporate that for patients in practice?
Yeah, I think it would be super important for us to do that. And I know there are some scales that are pure, like you don't ask the patients anything, and they give an idea, a concept of frailty. I don't know. Do we have that in our like geriatric storyboard or 5M storyboard? Do you know?
We don't.
Okay. But I also think it's important that it's the interdisciplinary team who's assessing this as well. So, in seniors clinic, in the ACE unit, I think those are very useful scenarios where we can have people thinking about frailty.
And just to add to that, I think on the inpatient side, it's probably very important, especially when somebody's already suffering an acute insult and they're hospitalized for it, is like how, what interventions are we going to do, and are we going to make this patient worse, or how are we going to make them better? It's really hard to get anything put into Epic on a high level, but for example, like frail scale could be included, I think, in Epic. If we could get that, we could even maybe push to get that into the 5M storyboard or the 4M. We have it as in there now. And who would do this? Is this something our medical assistants could do on their long list of things already? I don't know. Is this, we don't have traditional nursing. Our nurses more or less do triage. Is this something that we should have, a cheat sheet just to give to the patient like we do for a GDS? Is this something that could be a self-reported measure? I'm not sure, but thank you. It's a great question. Samantha, did you have a question?
Oftentimes, I see folks from behavioral health that part of the goals that we're working on is how they can implement exercise or just physical movement of any kind into their routines in day to day. And one of the things I'm just curious your thoughts about this, and maybe my own is like when I'm working with a patient that I'm perceiving as more frail, I tend to be a little bit more fearful about exercise goals because I'm like, are you doing physical therapy? Do you already have like an exercise plan? Like I feel a little bit more cautious about having them kind of create their own goals without some kind of oversight because I don't want to, increase risk of injury. And I'm just wondering what your thoughts are about walking that line between wanting to encourage more physical exercise, particularly resistance training, as you said, and balancing that also with making sure that they're doing it in a way they're implementing. A lot of what we're doing is implementation of new behaviors, right? So how we can balance the need for more physical activity with also kind of being careful with how it actually is. Any thoughts about that?
Just quickly to summarize for our online folks, Dr. Farrow from the Behavioral Health Group is asking about when working with patients on motivation and increasing physical activity, how do we cautiously counsel them, recognizing that frailty may be a component of their clinical syndrome and recognizing that we don't want to cause harm, but only benefit?
So I think about like the 3 domains of activity. So we talk about resistance exercise, but walking also gets at cardiovascular exercise. And then finally, the third one is balance. But I would say about balance training, that should be happening 3 days a week. And I think that should be prescribed, because I think it's so variable about what's safe for our patients. So I think that's something that the provider should provide input on. As far as resistance training, I think at the end of the day, I think we've talked about this before. I think Jen's mentioned this, just even doing chair stands just during like commercial breaks or between chapters in book. Dr. Schwartz said that, ask them if they're a book reader or a TV show watcher, and then have them just do some chair stands. I just say, do some chair stands until your legs feel tired. Some of them, that's one. And if they just start even implementing at that level, we can increase their resistance training. And if they're a little bit more steady, you can have them just even do heel raises.
Last question, Dr. Parnes.
This frailty is so common in 95+100-year-old, and patients are often described either formally or presentation as a 98-year-old frail white patient. I think we should, since as you pointed out, there are 95-year-old and even 100-year-olds that are not frail. It's actually part of the presentation to kind of prevent ages to say this is a 98, Steve is 98-year-old non-frail. That he pointed out that the side is not very high.
For our online listeners there, this is a question about should we advocate for the inverse of frailty when recognizing that in older adults, to define them as, a 90-plus-year-old individual, non-frail with a past medical history, et cetera, et cetera.
I think you bring up a great point of how we frame our patients in our presentations, and I think that's really good. And I think that's something we as geriatricians can really advocate for. And I think you bring up a great point. So talking about this is a 95-year-old robust patient, or this is a 76-year-old frail patient or a less robust patient. I think that should be something we discuss because, when we're having our learners, especially create these frameworks in their minds, I think that could help them in the future. Okay, I have a different concept of this frail versus this robust patient, regardless of age. I think that's a great point.
Thanks so much. I wanted after a picture for this kicking off. So 1, 2, 3. Thank you.
Thank you so much to our speakers, Doctors Gretchen, Orosz, and Thomas Johnson. Thank you so much.